opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introductions of our speakers to Martha Butterfield, the Program Coordinator of NJCTS. Marty?
Thank you, Kelly, and good evening, everyone. We're pleased to offer another webinar in our anxiety series. Tonight we will discuss anxiety in children, things to watch for, and when it should be of concern to parents. Tonight's presenter, Dr. Yevgeniya Ratnovsky, a postdoctorate fellow at the Child and Adolescent OCD, Trichotillomania, and Anxiety Group in the Department of Psychiatry at the University of Pennsylvania School of Medicine. She received her bachelor's degree at Arcadia University, her doctorate in clinical developmental psychology at Bryn Mawr College, and completed her clinical internship at the Devereaux Foundation. Dr. Ratnovsky is a certified school psychologist working in both public and alternative schools. She specializes in the treatment of children and adults with anxiety and tic disorders, OCD, and trichotillomania. Additionally, Dr. Ratnovsky conducts psychological evaluations, consultations, and psychotherapy in a variety of clinical settings for children and adults with anxiety and mood disorders, as well as behavioral difficulties. Her current research interests include investigating the efficacy of cognitive behavior therapy for trichotillomania and OCD in pediatric populations. It's now my pleasure to turn the presentation over to Dr. Ratnovsky.
Hi, everyone. So today we'll be talking about developmentally appropriate anxiety and what you as parents, teachers, health professionals can do to first identify the anxiety in the child and also to help. So we know, everybody knows that occasional fears and worries that come and go are in fact a normal part of childhood. However, for some kids, this developmentally appropriate phenomenon may actually be a sign that there is an emerging anxiety disorder, which can potentially impair their functioning. And today, we'll be talking a lot about how to determine whether a child's anxiety has reached the status of a disorder or whether it's something that's still in a normal realm. So in terms of the agenda for today, we'll first review the types of anxiety disorders that are out there and are being diagnosed in kids, because that way you can figure out if that is something that your child is dealing with and their anxiety actually fits that particular category. We'll also talk about strategies that parents can use to minimize the impact of anxiety on everyday functioning of the child. We'll talk about when it's time to look for professional help, when it's no longer enough for the parents and teachers to be trying to deal with the anxiety issues of the child. And also, I'll give you some self-help resources, like books for children and for parents and for teachers. So what does developmentally appropriate anxiety look like? There are a few things that we'll look for to try and determine whether anxiety is in fact normal for the child's developmental level. First of all, if worries are relatively occasional, so the child is not constantly worried about something, whether it's different things or the same topic, but if worries come and go, they're transient and don't stick around, the child doesn't look more scared than other kids his age. So, you know, on a particular night, everybody might be scared of ghosts, but if your child is not looking that they're 3 times more scared of ghosts than all the other kids, then it's likely that it's not pathological anxiety. And also if the child's anxiety does not get in the way of his or her functioning. So if the child is able to go to school, go to sleep, interact with peers in a developmentally appropriate way, then it's likely that anxiety has not reached a clinical level. So when does anxiety become a disorder? Just to give you some numbers, there are approximately 10 to 20 kids who are diagnosed with clinical levels of anxiety in the U.S. So clearly it's a very prevalent issue in our country. And it can be tough to identify for parents and teachers because oftentimes kids with an anxiety disorder might only complain about physical symptoms of anxiety, and that's really a hallmark of an anxiety disorder with kids, that they tend to complain about stomach aches and headaches and so on, nausea, but might not actually discuss the thing that they're scared of. Oftentimes they might not even be aware of it. And oftentimes also parents and teachers accommodate a child with an anxiety disorder. So that way the child successfully avoids all the fear-related situations, and as a result parents might not figure out that it's a problem at all, because the child is really not faced with a situation where anxiety would occur. So in order to determine whether the child's anxiety is in fact a disorder, we typically look for a few things. So first of all, avoidance. Is the child actively avoiding situations that might be making them anxious? Is the child avoiding going near dogs if they're afraid of dogs? Is the child avoiding going swimming if they're afraid of water? Is the child avoiding going to sleep if they're afraid of ghosts? We're looking at interference. So I briefly mentioned that before. Is the child's anxiety getting in the way of his or her functioning? So is it getting in the way of getting academic work done, spending time with friends, spending time with family? Is the child's distress reaching such high levels that they're becoming debilitated, and when they're feeling anxious, not able to shift gears and do something different? They're not able to they seem to get stuck on those anxious thoughts in the anxiety-provoking situation. And if that's happening, then that's a good indicator that anxiety is reaching clinical levels. And finally, what's the duration of anxiety? So when confronted with an anxiety-provoking stimulus, is the child staying anxious for a long time, or are they kind of anxious for a little bit and then they kind of forget about it when they leave the situation? Also, has the child been anxious for weeks or potentially months, or in some cases years? Or is it something that only started a few days ago and potentially is already the symptoms are already declining? So why pay so much attention to anxiety? First of all, unlike other kinds of psychological problems, for example, certain behavior problems like oppositionality or hyperactivity, oftentimes kids and adolescents with anxiety disorders don't get noticed. And if anything, they might look more like really overly good kids. And as a result, they might end up suffering in silence because they're really not calling attention to themselves in many settings, like a school setting, because they're the kids who are doing their homework on time and not disrupting the class. However, we know that anxiety disorders in childhood predict educational underachievement. So if you're so anxious that you can't concentrate on what you need to do for class, or you're not able to complete homework because you want to make sure you're doing it perfectly, of course that will interfere with the functioning of school. We know that anxiety derails from developmental milestones, achieving developmental milestones, because anxiety often leads to avoidance of certain types of situations that might allow the child to develop certain skills. So for example, if an adolescent is severely socially anxious, they might avoid any kind of interactions that might allow them to go out on a date. So that child might not ask a girl out on a date, and as a result might not have the opportunity to develop dating skills. We know childhood anxiety is also strongly associated with depression, which kind of makes sense, since if you're feeling so anxious that you're not able to do certain things and you're kind of feeling uncomfortable a lot of the time, it's likely that you're going to start to feel hopeless about the future and sad, and that could potentially lead to depression and in turn at times even suicidal ideation. And finally, we know that childhood anxiety may predict substance abuse problems in adulthood, as well as depression and anxiety disorders in adults. So oftentimes adults may say, well, you know, the child is anxious, but he'll grow out of it. And if it's developmentally appropriate anxiety, he probably will. However, if anxiety is at the level of being a disorder, it's possible that it will grow into other kinds of problems or stay an anxiety disorder when they become adults. So here's a list of the majority of anxiety disorders that are typically diagnosed in youth, so in kids and adolescents. And we'll go through the ones on this list today in a minute. But the one thing that they all have in common, even though they might have different symptoms, they all have intense anxiety as a major symptom. So anxiety that is out of proportion to the actual thing that they're facing, and they all result in functional impairment, meaning that they interfere with a child's ability to function. So the first disorder typically diagnosed in school-age kids is separation anxiety disorder. And of course we know that some separation anxiety is expected, especially at specific ages. So for example, toddlers are expected to show separation anxiety when they're asked to leave their mom or dad or any other primary attachment figure, and that's normal and that's expected. However, typically this kind of anxieties are supposed to start decreasing and kind of resolve itself by the time the child is 5 or 6 years of age. So when you see separation anxiety in children between the ages of 7 and 11, then we start to worry whether it's in fact a disorder. We know that approximately 2 to 3% of grade school kids do likely have that diagnosis of separation anxiety. And the way that you can tell a child with separation anxiety is that they have much fear about being away from home, and oftentimes not just being away from home but also being away from their parents or other primary attachment figures. So they might worry that something bad will happen to them, or they might worry that something bad will happen to their parents, which is why they don't want to separate from them. As a result, they might not want to go to school, so you can see some school refusal in that population. Also, as many kids with all kinds of anxiety disorders do, they have a lot of somatic complaints, so things like feeling nauseous, sometimes even throwing up, stomach aches, muscle aches, feeling restless. And these kids will ask parents a lot for reassurance about their safety and their parents' safety. So questions like, are you sure that an earthquake is not going to happen today and that you won't be able to get me from school as a result of that disaster? So the next anxiety disorder I'd like to talk about is social anxiety disorder, and basically it's a fear of one or more social situations where people are exposed to unfamiliar people around them, or potentially even familiar people at times, but attention is on them, and they get worried that they might do something that might be embarrassing. And in fact, sometimes the worry is so strong that it might even cause panic attacks, which are severe instances of anxiety that are quite unpleasant. People with social anxiety disorder also have a lot of somatic symptoms. They might also avoid school. So there might also be some school refusal, but not so much because they're like trying to avoid academic work or necessarily separating from their parents, but because they just don't want to face certain social situations that they're expected to deal with in a school setting. And other school problems that they might have include having to do certain types of projects, like for example group projects or doing oral presentations in front of the class. So kids with social anxiety disorder might do everything in their power to skip those. And one disorder that's not quite social anxiety disorder, but that we think is linked to social anxiety is selective mutism, which basically involves the child not speaking in certain settings. A child who speaks normally at home but might refuse to speak in school or to speak in front of unfamiliar people. And oftentimes it's diagnosed in younger kids, though it certainly can be diagnosed in kids who are 10 or 11 as well, though it's less common than in 4 or 5 or 6-year-olds, for example. But we think that selective mutism is very much related to social anxiety because kids might be worried about saying something wrong or the way their voice sounds, for example. So oftentimes kids with selective mutism, especially if untreated, become kids and adults with social anxiety disorder. Generalized anxiety disorder is really kind of almost what it sounds like, what the name sounds like. It's basically worrying about all kinds of different things, but different from developmentally appropriate worry, where a child might worry about not performing well on a test, for example. A child with generalized anxiety disorder might worry about that kind of thing as well, but they worry so much that they're not able to eat dinner that night, that they're not able to go to sleep, that it might cause them some somatic symptoms like diarrhea and headaches and tension. They might constantly be obsessing over the possibility that they might fail and what that might mean for their future and their ability to go to college and become a doctor. So really kind of blown out of proportion worry, even if the content might be appropriate if only the anxiety was a little bit lower. So they're the kids who are called worrywarts typically, and they can come up with what-if scenarios pretty much on any topic that you give them. Typical worries include worries about competence, worries about things that they might have done in the past, being on time, what their future might look like. These kids, besides having a lot of somatic complaints, might also be irritable and have trouble just letting go and relaxing because they're constantly tense and wound up and worrying about all kinds of different things. So panic disorder is a disorder that was once thought to not come up in kids until actually they became adolescents at all, but now we actually know that kids, even as young as 5 at times, can have panic disorder, though it certainly happens much more often in adolescence and adulthood. So panic disorder involves having multiple unexpected panic attacks, which are episodes of very intense anxiety that includes a lot of somatic symptoms like heart beating very quickly, sweating, feeling like the person can't breathe, feeling dizzy or lightheaded, feeling like there's tingling in the hands and feet, and also some cognitive symptoms that go along with it. For example, the fear that the person might be losing control since the feeling is so strong, that they might be having a stroke or a heart attack, that they might be going insane. So obviously these episodes are pretty intense and unpleasant. And in order to qualify for a panic disorder, the child needs to be worried about having other attacks. So if they have these attacks and it's no big deal, it's not really a problem. But if they're often worried about having another attack and are potentially avoiding situations that where such an attack might occur and they might not have an easy time escaping, which is really what we call agoraphobia, so worry about being stuck in a place that they can't escape from, then it really becomes a problem. Panic disorder can be in the presence or absence of agoraphobia, so the child doesn't have to have the worry about being stuck in certain situations from which escape is difficult, but it often does co-occur with panic disorder. And of course you want to make sure that these symptoms are not the effect of some kind of substance or medical condition. So sometimes hyperthyroidism might kind of look a little bit like panic disorder, or ingesting something like cocaine, for example, might induce panic attacks. The specific phobias, they used to be called simple phobias in the past. Those are fears that are in excess of the situation that's being faced, or an object that's being faced. And they're very specific kinds of fears, hence the name specific phobia. So it could be a fear of flying, fear of heights, fear of needles, fear of certain animals or insects. And the person might try to avoid the situation if they possibly can, but if they can, they tolerate it, but with a lot of difficulty and anxiety and distress. And the person typically realizes that their fear is excessive and that it doesn't make sense, but they just feel like they can't really control it. In younger children, they might not actually have that insight that their fear is excessive, so they might actually believe that the situation does in fact need to be feared. And finally, obsessive-compulsive disorder. So it's a disorder that often begins in childhood. In fact, at our center, we're doing a study with kids who come in as young as 4 or 5 who already have symptoms of obsessive-compulsive disorder or OCD. And about half of adults say that their symptoms, half of adults who are diagnosed with OCD say that their symptoms actually began in childhood. So obsessive-compulsive disorder is made up of 2 components, as you can tell from the name, obsessions and compulsions. And obsessions are very intrusive thoughts that cause anxiety and that keep recurring over and over again. They might be kind of verbal thoughts, they might be impulses or images, and they cause a lot of discomfort to the child. And some common obsessions in kids and teenagers can include contamination, so worry about germs or getting sick, getting AIDS, the safety of people around them or their own safety, so worry that somebody might break into the house, that somebody might rape them, that somebody might hurt them in some way. And excessive doubt, so worried about whether the doors are locked, worried about whether they remembered their backpack, so kind of doubting their memory. And scrupulosity, which is worry about whether they're a moral person. Sometimes it takes the form of religion, worrying about whether they're behaving in a religiously right way. And the second part of OCD are compulsions, or sometimes they're called rituals. And so those are behaviors, either behaviors that others can see, or sometimes they're mental acts, so things that a person does in their mind that others cannot see, which basically a person does in order to relieve the anxiety or discomfort associated with obsessions. Obsessions give a lot of anxiety and discomfort, so the person feels like they have to do something to get some relief. And so they end up doing the compulsion in order to get that relief, but also sometimes to prevent a dreaded outcome, for example, somebody breaking into the house. Oftentimes, and compulsions, of course, are related to obsessions. So if a person is worried about getting sick from germs, they might be washing their hands a lot. If the person is worried about somebody breaking into the house, they might be checking locks all the time. If they're worried about their safety, they can also be asking parents for reassurance constantly, kind of asking 50 questions in 15 minutes. And there could also be some mental rituals like counting until a lucky number to make sure that nothing bad happens, for example. Compulsions are not fun to do, but people report that they feel like they have to do them because otherwise they'll never get rid of anxiety or the dreaded outcome will occur. Okay, so now that you know what anxiety might look like in the more extreme form or in the form of an anxiety disorder, what can families do to try and relieve some of the anxiety that their child has, or to help them overcome the avoidance that actually ends up breeding more anxiety in the long term? And of course, if it's a true serious anxiety disorder, a lot of the times parents and teachers helping the child may not be enough. But there are certainly certain things that they can do to help to move the child along and try to help them not kind of fall into the clutches of an anxiety disorder and try to relieve some of the symptoms. And parents and teachers, of course, can also help the therapist who might be working with a child to practice some of the things that they're doing in therapy at home. So that's what we'll talk about. And in fact, I'll give you some ideas of the role of the family, trying not to get too much into the actual treatment theory and how treatment is conducted, but my colleague, Dr. Diana Antinora, in a couple of weeks will be talking specifically about the treatment of anxiety disorders and exactly what therapists do and what else families can do to help. So First of all, a hallmark of anxiety disorders is avoidance. So kids who are anxious try to, as do adults, try to avoid the situations that make them anxious and that cause them discomfort. However, because they avoid it all the time, they get more and more sure of the idea that the situation is dangerous, and that if it's easier not to face it than face it because they've been avoiding it for so long. And if not facing you makes you feel better, then of course that's the right thing to do. That's kind of the conclusion that they might implicitly come to when they continue to avoid the situation. However, we know that avoidance doesn't belong in the long term, because the more you avoid, the harder and harder it becomes to face the situation that you've been ignoring for so long. So instead of avoidance, it's a good idea to teach the child the approach strategy to dealing with fear and anxiety. So in the approach where we slowly, very gradually face situations that cause anxiety, when we face them, at first there might be some fear. In fact, oftentimes there's a lot of fear, even if you start out with things that you haven't faced for a while that shouldn't cause too much anxiety. But as the child stays in the situation, it becomes easier and easier to deal with it. For example, if they're worried about dogs, the family might try and figure out how can we expose the child to dogs without them feeling too overwhelmed with anxiety at first, and how can we teach the child to approach dogs and to be able to be around them, as opposed to right now when they run to the other side of the street or maybe straight home when they see a dog. So first approach should be gradual. So you might start out with a child who is afraid of dogs, first looking at photos of dogs and maybe looking at videos of dogs for a while, then potentially walking on the other side of the street from where the dog is but not running all the way home, then maybe being in the same house but not in the same room with the dog, then potentially being in the same room and finally getting to petting a dog, maybe a small dog at first and then a bigger one. So that would be a very gradual approach to learning how to be around a dog for somebody who has a phobia of that particular animal. And at first, as each new situation is faced, the child might experience a surge in anxiety and they might feel very uncomfortable. However, as they stay in the situation, they don't avoid it and they don't run away from it. Even when feeling anxious, the anxiety slowly decreases and the child gets the sense of mastery. So that's kind of the idea between approach and avoid. That's kind of the idea behind the approach kind of strategy towards facing fears as opposed to avoiding it and growing the fear. And parents serve as coaches and models for kids in this kind of therapy or this kind of strategy. So they firstly encourage the approach of anxiety-provoking situations, but they also model distress tolerance. So for example, if you might want to walk through this kind of approach strategy with something that you're afraid of. So maybe going on a roller coaster, for example, you might tell the child that that is something that you're worried about and you're going to work on it, and even though you feel pretty anxious, you're going to tolerate that anxiety and do the thing that you're scared of anyway, because later on it's going to help you be less scared. In terms of the family processes that are typically involved in this, oftentimes parents, as I mentioned briefly before, accommodate a child with an anxiety disorder because the child clearly shows a lot of distress. So it's important to start removing some of the accommodations and tolerate the child's distress as they're facing their fears, and letting the child know that it's okay to feel anxious, and that eventually, as they get better and better at this, they will feel more comfortable. And of course, we want to reduce the criticism of the child with an anxiety disorder as much as possible, because it's something that's really not in their control. And instead of criticizing the child, that might make them feel kind of bad and guilty about it, which they might be feeling anyway, if parents can engage in some problem solving, that would be the best strategy to try and deal with the child's anxiety. So why is it difficult, in fact, to help the child at times face the things that they're afraid of? Why is it difficult for the parents? So here you see a few different things that oftentimes need to be taken into account when parents are kind of struggling with this idea of having the child feel distressed. First of all, you know that from an emotional point of view, you're supposed to protect the child and decrease their distress. So what kind of a parent am I if I'm letting my child feel very anxious? From a functional point of view, you know, certain things just need to happen on time. Dinner needs to happen on time. You need to get to work on time. You need to get to school on time. The child needs to get to school on time. So it's often easier to just kind of accommodate the child and do something to help them not feel as anxious and not let them face that anxiety-provoking situation. And finally, you also don't want the child to kind of be shunned from their peers because they're using some kind of strategy that might look kind of weird to other people. So I know that might be a worry of parents as well. As we began talking about before, accommodation typically occurs, and parents often try and change the environment around the child in such a way that anxious thoughts, anxious feelings, or urges are lessened because they're trying to kind of remove all of the anxiety-provoking things that might trigger the child. And as a result, they provide relief or escape from those kinds of uncomfortable feelings. However, we know that avoidance and accommodation do not help. First of all, we know that over the long term, it maintains anxiety and makes anxiety worse because, as we talked about before, it's harder and harder to face situations that are difficult if you're used to avoiding them. The child often feels kind of stuck in what they're doing, and as they're not really changing their behavior over time, they might start feeling frustrated, and that might spill over into family relationships and relationships with the parents, because the child might be blaming the parents for pushing them to do something that they might feel anxious about and that they're used to avoiding. The child's world might shrink, meaning that they might not, as a result of severe anxiety, they might not be able to function as well as they should. And so they're maybe not going out with friends anymore, they're not going to school regularly, and they're not functioning well in school when they're actually there. And sometimes children like that can actually become depressed because as they're avoiding and having environment changed around them by their parents, they're really kind of not facing the thing that they're afraid of, and as a result, they're not feeling that sense of accomplishment that they can overcome that difficult thing, so they're starting to feel hopeless. And just as a quick example of somebody who had this kind of issue, it's one of the patients that we have treated at our clinic with, of course, personal details changed. This was somebody who was 10 years old and had severe separation anxiety. And she's had that kind of anxiety since preschool, but it became worse, I believe, in 4th grade. And she often avoided school. She often stayed home with mom. Even the times when she went to music and dance lessons, she did not allow mom to leave the parking lot, so the mom would stay for hours in the car waiting for her daughter to be finished. She had special rituals that she did to reduce some of the anxiety. So she always had like a lucky pen with her that was supposed to keep her safe. And she was asking mom lots of different questions, looking for reassurance about the day, so making sure that mom said that nothing bad was going to happen today. And when she was away from her mom, she often called her and checked up on her and made sure that her mom was safe and that everything was okay. As a result, patient stopped being able to attend school regularly, and school became pretty upset about that and threatened to have her transferred to an alternative school if things didn't change. There were fewer social interactions because she couldn't go to sleepovers, and even kind of she couldn't be away from mom even for a day. There were arguments with parents over her avoidance of lots of different situations that she was expected to deal with as a as an older child, and she was starting to feel depressed because she was seeing how much impairment she was experiencing as a result of the anxiety, and that she wasn't like her peers in many ways. So that's basically where avoidance and accommodation kind of really made the problem worse. So what can you do to help your child? So the first thing, as we've talked about for the last few minutes, is encouraging, approaching, and tolerating the distress during those stressful situations, rather than trying to escape the situation and get some relief from the discomfort. Because we know that over time that distress is going to go down if the child only gives it a chance and doesn't engage in avoidance. And there are a couple of different things that you as parents can do to help encourage that approach. So the two things are scaffolding and contingency management. So scaffolding is really the idea that we build on the skills that the child might already have. So the first step in scaffolding would be to explore and figure out what the child's feelings are, and then to empathize with her feelings. So for example, if a child is afraid of needles, trying to figure out what is it about the needles that the child is afraid of. Is it seeing blood? Is it feeling the discomfort? Is it feeling kind of out of control when the needle is coming at her? And trying to really explore what it is that scares the child about the situation, and saying, it's understandable that you're scared of this. It's not pleasant to have a needle go into you, and lots of kids are scared of it, as opposed to blaming the child for having those feelings. The next step would be to brainstorm some of the benefits of deciding to work on the fear and deciding to face it. So, saying to the child, well, let's think of what kinds of things you will be able to do once you get over the fear of needles. Well, you wouldn't have to worry so much before doctor's appointments. You'll be able to watch movies that have scenes where a child is getting a shot in them, and you don't have to turn away. You don't have to dread going to the dentist. And basically, we want to teach the child that being uncomfortable is okay, because we are trying to work towards a better future, and kind of looking at the bigger picture of being able to be more comfortable and being able to do more things in the future. And that's the reason why we would like her to tolerate discomfort now. The third step would be to decide on a plan and follow through with that action. So with the fear of needles, you might want to figure out what would be a gradual way in which the child can approach needles and start to slowly get used to being around them, and eventually having a shot or having their blood drawn. So deciding what that first step should be, for example. Should it be looking at pictures of needles in the computer? Should it be looking at somebody getting a shot in the cartoon? And then after the child follows through with the action, evaluating how they did. Were they able to go through that whole practice? Were they able to, in fact, sit through the whole cartoon where a child was getting a shot? Or, did they sometimes look away? So trying to figure out which parts were difficult, which parts were easy in the situation, and then rewarding the child. And we'll talk about rewards in the next slide. So positive reinforcement is a term that we hear a lot. And basically all it means is that it's something that we do that increases the behavior in the child. So rewarding the child with positive attention when they do well. So giving them lots of attention, screaming yay and good job when they actually approach the feared situation. Removing attention when they're engaging in behaviors you don't want them to do. So, not really saying anything, not paying much attention, not making a big deal out of the times when they look away or they cry out or, they get really upset, but kind of, giving them minimal attention and redirecting them back to approaching the thing that they're supposed to be working on. And finally, just plain old rewards. So praise and encouragement, so they could be verbal rewards. They could be tangible rewards like getting an ice cream for watching a movie that had needles in it. and then having access to certain privileges, so being allowed to play the Wii for half an hour that evening, for example. And you want to teach your child really approach as a lifestyle. So it's something that we do consistently, not just for the fear of needles, but pretty much for any situation that gives us discomfort. As long as it's actually objectively safe, we want to make sure that we're approaching it instead of avoiding, and we're not feeding our fear. And this will promote the internalization of these ideas, so the child will really make it part of their life philosophy. Because really the take-home point here is that we don't want anxiety to interfere with anything that the child does. We want them to live their life the way they want, despite the anxiety, even if the anxiety is there. The idea is not to change your plans over it. So when is it time to do more? When should somebody look for help for their child? Well, first of all, if anxiety is very distressing, if it's getting in the way of functioning, and if really it can no longer be managed by parents and teachers effectively, so that the child in fact engages in approach strategies and begins to work on it, then it might very well be time to look for a professional who can help with the situation. And the longer the problem continues, the harder it may be to treat, because the child's behavior gets more and more ingrained, so they get more and more used to avoiding these anxiety-provoking situations. So as soon as you identify that there is a problem that the child might need help with, it's a good idea to look for that professional. And here I've listed some websites where you can go, and I think in most of them you can search by your geographic location to try and figure out where you can look for therapists who in fact specialize in pediatric anxiety. If you go to kind of just any person out in the community, they might not necessarily use empirically supported treatments or treatments that have been shown to be very helpful for kids with anxiety disorders through research. So you want to make sure that you definitely explore and figure out whether the professional that you are going to be taking your child to does in fact know how to handle childhood anxiety in a way that will be most helpful to you and your child. And here I have a list of some books for parents and teachers that you can look through, as well as books for kids with anxiety disorders, different kinds of anxiety problems actually, and some for developmentally appropriate anxiety as well, like facing the first day of school, for example. And finally, the group that I work for, the Child and Adolescent OCD, Tic, Trick, and Anxiety Group, or we call it COTTAGE for short since we have such a long name. We, of course, have many professionals who treat anxiety disorders in kids. And so here you have our contact information, our website, as well as our phone number if you want to either refer somebody or make an appointment for your child. And we offer lots of clinical services that you can see here, as well as we consult with schools and do parent and teacher workshops. So that's something that we can offer as well. Thank you. At this point, I'm ready to take questions.
All right. Thank you very much. I just want to tell folks who are listening that the doctor's made her slides available. So that information about the books and those details there are certainly available for you to see them and be able to spend a little bit more time reading the information there about books and resources. So to my first question, I'd like to clarify something you said in the beginning, and unless I heard it wrong, I just want to understand what is the prevalence of anxiety in children?
Right. So good question. It's actually, there isn't an exact number because depending on the study, there are different numbers that are being cited. It's estimated that it's between 10 and 20% of kids in the U.S. who might qualify for the diagnosis of an anxiety disorder, which is quite a high percentage.
It is, yeah. And then I wasn't sure if I'd understood that correctly, so I just wanted to make sure I got that right. Mm-hmm. Can you discuss how school professionals should counsel teachers and parents when they believe they've identified a student with an anxiety disorder?
So first of all, a school professional might might let the teacher and the parent know, first of all, that it's not uncommon. So normalize it a bit for especially the parent, who might be quite worried that they're having these symptoms that seem kind of out of proportion to the situation that they're typically facing. So normalizing it as much as possible for the parent and the teacher too, who might be seeing a lot of this in the classroom. And then the next part would be to suggest the different resources that the parent might access to see if they can get some consultations or potentially empirically supported treatment to help that child. And also letting the teacher and parent know that even though it might be tempting to accommodate the child with anxiety, in the long term it's not helpful. Because it only, as I talked in my presentation, it only ends up growing that anxiety long term. So there might be some accommodations that might need to be made in the beginning, maybe giving them a little bit more time if they're worried about not completing everything on the test, but it should only be done in the context of the child working either with a therapist or the parents and teachers together on facing the fear and kind of doing only having the accommodations happen if they're temporary as opposed to permanent, and kind of letting the child know that they will never be able to tackle that test in the time limit that that's given to all the kids.
Okay. I think one of the key things there, though, is that the teachers and parents really need to work together. If this has been something that's been identified, that it has to be a cooperative thing going forward.
Right, absolutely, especially if the anxiety symptoms are manifesting themselves in the school setting. So oftentimes teachers might not even know that a child might have an anxiety disorder because for the most part those symptoms occur within the home, and then the teacher might not have as much of a role to play. But if the anxiety symptoms like perfectionism on tests, for example, or school refusal, because of potentially embarrassing social situations that are occurring in the school setting, then the school counselor, school psychologist, potentially teachers, parents, and the child really do need to all work together to figure out how can we handle this problem in the short term and what are we going to do about it in the long term.
Mm-hmm. Okay, thank you. Can you speak a little bit about the problems of OCD and the impact that it can have on siblings? This parent says that they see frustration in their younger son when his brother is so focused on his compulsions that he seems to reject the younger brother.
Right, and unfortunately that certainly does happen with a lot of anxiety disorders, certainly with OCD, where the behaviors can seem kind of sort of bizarre and not understandable to the younger child, for example. So the first step would be to discuss what OCD is and the symptoms of OCD in age-appropriate language to the younger siblings so that they understand that it's not anything personal, but it's something that kind of takes a hold of their older sibling, and for a little while their older sibling is not him or herself. But instead kind of is listening to this thing called OCD. So that way the younger child kind of can understand that it's really not their older brother who is doing it to them, but it's that other thing called OCD. And also potentially giving some ideas of what the younger child might do when the brother with OCD acts in a way that makes them feel rejected. So maybe, you could give him a break for a little while and go to your room or go outside and play. And we know that usually your brother feels a little bit better after 10 minutes or so, and then maybe you can come up to him then and ask him a question that you wanted to ask. Mm-hmm.
Okay, so give a little bit of space there.
Right, so giving some ideas of how to deal with the situation, and those ideas, really do depend on what the symptoms of OCD are and how they manifest themselves in that particular child. But, reassuring the child that it's not them, it's the OCD, and giving some solutions to how to handle that particular situation.
Okay. Is there a general age when you should consider treatment for an anxiety disorder? Or is it dependent on what type of disorder seems to be manifesting itself? So if it's I don't know if it's school refusal, for example, or something. Is there an age when it's more appropriate to try and treat that and less effective at a certain age?
Right. So generally, the earlier you can catch a disorder, the better it is. So sometimes we even have parents who have kids who are maybe just slightly more anxious than normal, but they're kind of young. They're maybe 4 or 5, and the parents are worried that the problem might become more intense as their child becomes older. Sometimes we even recommend that they bring them in, even if it's just for a couple of sessions, or even if it's just for a consultation with just the parents so they know what to do at home to help them. So in general, regardless of the disorder, as soon as the symptoms are there and as soon as you're wondering whether those symptoms are developmentally appropriate anxiety or not, you want to at the very least consult with a professional, because the younger the child is, the less they have the opportunity to practice those avoidance strategies, and kind of the less ingrained their fear is and their avoidance behaviors are. So as a result, you can treat it a lot quicker and generally overall with more success.
Okay. I have a question about obsessions that result in compulsions. Are there certain types of obsessions that result in certain types of compulsions? The question specifically has to do with what kind of obsession results in a touching compulsion. Is there any connection between one and the other?
Yes, absolutely. So obsessions and compulsions are functionally related, meaning that compulsions really the majority of the time very much have to do with neutralizing the thought or the obsession that occurs to the child. So in the case of touching, for example, it could be lots of different things. You know, it's not enough to just know the compulsion. You really have to kind of question the child about what's going on. But it could be because if I don't touch both of my hands to the handles on the chair exactly the right way, I'm going to get that not just right kind of feeling. It's going to be uncomfortable. I'm going to feel unbalanced. That could be the obsession. Or it could be some magical thinking, for example, that if I don't touch on each side of the chair twice, I'm going to something awful is going to happen today. Maybe my mom is going to die, or somebody's going to get into an accident. So absolutely, the two are very much related, because compulsions are really a way to relieve some of the distress that the obsession brings and some of the dreaded outcomes. But it's really difficult to say what the obsession is if we only know the compulsion, because the same compulsion might really be in the service of lots of different obsessions.
Okay, so they're not necessarily kind of paired together. They really are separate then.
Well, they're paired in that within one child, a particular obsession typically causes one or more certain compulsions, and they're very much related in that way, that, you know, if the child is afraid of germs, they're more likely to be cleaning and washing and so on. Yeah, exactly, or, you know, not touching certain things. But it's basically the same behavior, the same compulsion might kind of manifest itself as a result of different obsessions. So it's very difficult to guess the exact obsession just by looking at the compulsion, and that's when, you know, a thorough assessment comes in, or even just the parent questioning the child of, you know, what do you think might happen if you don't tap or touch.
Okay, thank you. Regarding what is developmentally appropriate anxiety, does it matter if the child is fixated on one thing or on multiple things? And the example given is there's this 10-year-old child who only seems distressed about driving when she knows that her grandparents are driving to their house. She seems to worry excessively about them, but not about other people driving. So it seems really focused on the grandparents.
Right. So in general, and this is not kind of, you know, a rule that works 100% of the time, but in general, the fewer fears and the less frequent and intense they are, the better the prognosis or the outcome for the child. So if they're only worried about, let's say, monsters under the bed, they're really worried about them, but it's only that one specific thing. Usually if they were to go into treatment, or if the parent would try to help them out, it's more likely that they'll recover quicker and more completely than somebody who worries about monsters under the bed and ghosts and needles and social situations and so on. So anxiety is more generalized. But on the other hand, something that might start out as one particular symptom, so for example, worrying about grandparents, might also grow to be other things as well. So maybe in a few months this child might worry about parents driving or her being in the car, or when her sister is riding in the car with with her friend's parents. So it's difficult to predict whether that anxiety is going to grow or just stay very specific. So it's generally a good idea for the parents, if it's not a big problem at the moment, if it's pretty circumscribed, to just kind of wait and watch the child and see if it becomes more generalized. Unless, of course, the anxiety is so severe that whenever the grandparents are driving, the child is incapacitated or is worrying so much that they're not able to pretty much do anything else or go on with their day. So then, even though it's pretty specific, it's only one thing, it's worth trying to figure out if there are ways in which you can help and have them potentially be evaluated.
Okay. Could you talk a little bit about self-talk? Can you explain what it is and, in your opinion, the value of implementing it, and how would you initiate that with your kids?
So self-talk is one of the cognitive strategies that people often use, both in cognitive behavioral therapy, which is a therapy of choice for anxiety disorders in both kids and adults. And in general, it's kind of a word that sometimes we hear in the pop culture. So basically, it's exactly what it sounds like. Self-talk are the things that we say to ourselves, so our internal conversation with ourselves. So how do we interpret a specific situation? What are we saying to ourselves about it? Self-talk in how it relates to anxiety disorders, and you can spend a lot of time talking specifically about that. Basically, is the interpretation that the child makes of a specific situation. So, if they're afraid of dogs, for example, are they saying to themselves, oh, that's a really dangerous animal, they could bite me and I'm going to be in pain and it's really not a good idea to be near them? Or are they saying to themselves, oh, well, usually dogs are friendly and I can come over and pet them. So it's the same situation, but they're interpreting the situation differently because they're saying different things to themselves. So when an anxiety disorder is being treated, or when parents or teachers are trying to help kids with anxiety disorders, they want to figure out what that self-talk is. What is the child saying to himself? What is it about the situation that they're interpreting as being dangerous? And then having them potentially change that self-talk, saying to themselves, oh, well, if my mom lets me be near the dog, she probably knows that it's pretty safe, so therefore I can come up closer and maybe even pet it. Or also, self-talk would be important when the child is practicing approaching situations that they're scared of, and in that sense, the self-talk needs to be more motivational. So the child saying to him or herself, probably with some modeling from the parents, I can do it, I'm strong, I'm brave, I know I'm going to be anxious for a little while, but then it will get better, and I know I can overcome this fear that I have, and in the future I'm not going to be so scared.
Okay, so some of those thoughts are in the kid's head, and that they're almost difficult to deal with if you don't know what the kid is thinking.
Absolutely. So,
So how would you initiate something like that with your kids?
I mean, a major job of somebody who is trying to help a child with an anxiety disorder, whether it's a parent, a teacher, or a therapist, is trying to figure out what the kid is thinking. So just asking lots of questions about, what do you think is dangerous about the situation? Why do you think this kind of thing scares you? What do you think is the most scary thing about it? And saying it in a way that's empathetic and kind of not non-judgmental, but kind of saying to the child that, I understand that you're scared and we'll figure it out together. And if you're approaching it in such a way, if you're asking questions in kind of a non-judgmental, open way, the child might very well be very happy to tell you what it is about the situation that's making them scared, if they're in fact themselves aware of it.
Okay. Do anxiety disorders typically run in a family? And if they do, how is it then possible for parents to be coaches and model tolerance and so forth when they're really struggling with some of this stuff themselves?
Right. That's a really good question. So yes, absolutely, anxiety disorders run in families, and it could be explained from a genetic point of view. And we know that it is, in fact, there is a genetic component to it, but also from the point of view of the family environment. So if a parent is anxious and has a true anxiety disorder, so they're avoiding things, they're teaching their child who is predisposed to having anxiety to also avoid things, and therefore kind of in a way, without meaning to, encouraging the development of clinical levels of anxiety. So first of all, it would be very important for the parent with an anxiety disorder to realize that they have one, and to first make sure that they're getting either professional help for it, or they themselves are working potentially with a self-help book, or somebody who might kind of coach them along, that they're facing the situations that they're scared of before they can start teaching it to their child. Because kids, of course, are going to pick up on the fact that, well, mom is afraid to drive, and she doesn't drive, she has dad drive, but she wants me to go to the doctor and get a shot, even though I'm really scared of it. So, of course, you want to make sure that your own anxiety is under control first before you start having your child be coached by you. But in many ways, it could actually be a great opportunity for both the child and the parent to work on the things that they're scared of. And especially with an older child, a parent can very much level with the child and say, I kind of struggle with fears too, and why don't I work on my driving, and you work on your worry about getting shots, and we'll kind of figure it out together, and maybe, we'll both be stronger people for it.
Yeah, and both support each other.
Exactly.
Yeah. All right, we're almost out of time. I think I have time for one more question. And so the question is, how would you assist a family when the student refuses to leave home to come to school, despite working with a therapist and also on medication, and the child just is in a terrible situation right now, it would seem?
Sounds like a terrible situation. I mean, that's a tough one. First of all, you want to, well, first of all, from the very beginning, school refusal is a very difficult thing to treat, because once the child kind of realizes that there is a choice with school, that they can refuse to go to school, and school is really unpleasant for them for whatever reason, then once they kind of get a taste of that, it's more and more difficult to get them back in the school, because they realize that they have a choice about it. So it's a difficult one to treat. And first of all, you want to identify that the school avoidance is in fact anxiety-based. Sometimes there are other issues that have nothing to do with anxiety that might cause the child to avoid school. But once that's figured out, and if it is in fact anxiety that's motivating school refusal, then you want to make sure that the therapist is using an empirically supported treatment like cognitive behavioral therapy, where they're making what's called a hierarchy, a fear hierarchy, or a list of situations from the lowest to the highest in terms of how much anxiety the child exhibits in each one. So potentially starting out with something like, just driving to the school during the weekend and hanging out by the school building, then maybe sitting in the school library, but during the weekend if they're allowed, then potentially driving by the school on a weekday. So kind of trying to figure out what are the different steps, gradual steps that we can take to eventually get the child back into the building, at the very least, even if they're not yet doing work. So if the therapist and the parent and the teachers are doing all of that, potentially they need to review that plan, figure out if there are certain rewards that can be used that are especially motivating for the child, and kind of make sure that they're being very consistent with it. But it is a difficult one to treat, and unfortunately sometimes it takes a while to get through to a child like that. Just make sure that the treatment that's being used is in fact a behaviorally based treatment that uses rewards and gradual approach of the anxiety-provoking situations.
Yeah, and I think the consistency there, I think, is really important too, between what the school is doing and what the therapist is encouraging and what the family is doing.
Right,
so
absolutely.
They all need to be on that same page.
Absolutely, because and oftentimes it's difficult, especially for the school, because they're trying to deal with hundreds and hundreds of children to be very accommodating to that one particular child. But in cases like that, it's absolutely essential that the school allows, for certain rules to be bent, like, for example, going to the school during the weekends or being in the school but not doing anything while in the school.
Mm-hmm. All right. Well, we are out of time, doctors. Thank you very much. Your great presentation, and I hope everyone enjoyed it. And I think I'm going to sign off.
You're welcome. Thank you so much for this opportunity.
Thank you for joining our webinar on developmentally appropriate anxiety, how to help, when to seek help. There is an exit survey which you should be redirected to as we end this webinar. If the thank you screen does not redirect you to the survey, try and click the link. We need everyone to fill out this evaluation. The discussion board will be open tomorrow and is available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the website. Our next presentation, Child Anxiety, What Does Treatment Entail for the Child and Family, will be presented by Diana Antonoro and is scheduled for July 27, 2011. This ends tonight's webinar. Thank you, Dr. Ratnovsky, for your presentation, and thank you, everyone, for attending.